Welcome, everyone. Today we're walking through three things you will touch in almost every clinical day: the instruments provider uses during a general physical exam, the supplies you stock and hand off, and how we throw things away safely. These may sound like three separate topics, but they live together in the exam room, and they are all part of your job as a medical assistant. You are the one who preps the room, anticipates what the provider will reach for, hands off the right instrument, and then cleans up and disposes of waste correctly afterward. By the end of this lecture, you should be able to walk into any exam room, name every instrument on the tray, explain what it's for, and confidently sort every piece of waste into the correct container. Keep your guided notes open as we go because you will fill in key terms and complete a sorting activity, and you will upload those notes to Brightspace for credit. Here's our roadmap for this lecture. First, we will frame your role. You are not a bystander in the exam room. You're the person who makes the visit run smoothly. Second, we'll go instrument by instrument through the tools used in a general physical exam, and for each one, I want you to know two things: what it does and why the provider needs it. Third, we will cover the everyday supplies you keep stocked. Fourth and fifth are about waste. We will separate three waste streams you will use every day, and then we'll spend real time on why putting waste in the correct container matters. The last point is not just a rule to memorize. It protects sanitation workers and coworkers. It keeps your office compliant with OSHA, and believe it or not, it saves the practice a surprising amount of money. Notice that the waste objectives carry the same weight as the instrument objectives, because in the real world, a sharp's mistake can hurt someone, so we treat it very seriously. Let's zoom out before we dive into details. Everything in the exam room falls into one of these three buckets. Instruments are diagnostic tools, the things the provider uses to look in the ear, look in the eye, listen to the heart and lungs, take a blood pressure, check a temperature, and test reflexes. Supplies are the consumables, the things you use up and restock, like gloves, gauze, paper on the exam table, gowns, alcohol pads, and specimen containers. And waste is everything you throw away, which is not as simple as one trash can because you have three separate streams. Your job touches all three. You prepare instruments so they are clean and charged, you keep supplies stocked so the provider never reaches for an empty box, and you dispose of waste correctly so no one gets hurt. A good MA thinks one step ahead. If you know the provider is doing an ear check, you make sure the otoscope has a fresh light and a disposable specula are within reach before the patient is even roomed. Hold on to these three buckets because we will spend the rest of the lecture filling each one in. Let's start with two instruments that share the same handle in most clinics: the otoscope and the ophthalmoscope. The otoscope examines the ear. It has a lighted, magnifying head, and onto that head you snap a disposable cone called a speculum. The provider inserts that cone into the ear canal, gently pulling the ear to straighten the canal so they can see clearly. Why do they use it? To look in the ear canal and the eardrum, checking for wax buildup, infection, fluid behind the eardrum, or a perforation. Your tip as the MA is to load a clean disposable speculum every time and confirm the light is bright because a dim light can make a healthy eardrum look abnormal. The ophthalmoscope examines the inside of the eye. It's a lighted instrument with a dial of focusing lenses, and the provider looks through it, usually in a dimmed room, to see the back of the eye. Why do they do this? Because the retina and its blood vessels are the one place in the body where we can directly see small vessels, so the eye gives early clues about glaucoma, diabetes, and high blood pressure. Your job is to dim the lights and make sure the instrument is charged. Notice the pattern we will repeat for every instrument. We'll go over what it does, why it matters, and what you do to get it ready. Next are two instruments that often work as a team, the stethoscope and the sphygmomanometer, which is the formal name for the blood pressure cuff. The stethoscope lets you listen to sounds inside the body, a skill called auscultation. It has earpieces and a chest piece with two sides, the flat diaphragm for higher pitched sounds and the cup-shaped bell for lower pitched sounds. The provider places it over the heart, the lungs, and the abdomen to hear heartbeats, breathing, and bowel sounds. Your tip is simple but important for infection control. Wipe the earpieces and the diaphragm with alcohol between every patient because that diaphragm touches a lot of skin. The sphygmomanometer or blood pressure cuff measures blood pressure. It is the inflatable cuff with a gauge. You wrap it snugly on the upper arm, inflate it, and then let the air slowly out while listening with the stethoscope for the Korotkoff sounds or heartbeats that mark the systolic and diastolic pressures. Why does this matter? Well, blood pressure is one of the core vital signs, and it tells us a great deal about heart and vessel health. The biggest MA tip here is cuff size. Cuff that is too small reads falsely high, and one that is too large reads falsely low. So matching the cuff to the patient's arm is part of taking an accurate reading. We will go over Korotkoff sounds when we dive a little deeper into blood pressures. Our last pair of core instruments is the thermometer and the reflex hammer. The thermometer measures body temperature, and you have several types. The common electronic probe can be used orally under the arm, which we call axillary, or rectally in the bum. There are also tympanic scanners that read the ear and temporal artery scanners that sweep across the forehead. Whatever the route, temperature is one of the vital signs, and a fever is often the first clue that an infection is present. Your tip is to use a fresh disposable probe cover for every patient and to chart which route you used because a rectal reading and an axillary reading are not interpreted in the same way. The reflex hammer, sometimes called a percussion hammer, tests deep tendon reflexes. The provider will tap a tendon, the classic example being just below the kneecap, and watches for the involuntary jerk. Why? Because the reflex arc travels through the nervous system, so reflexes that are missing or exaggerated can point to a neurological issue. The nice thing about the reflex hammer is that it needs no patient prep and no probe cover, so your job is simply to have it on the tray when a neurological exam is happening. Again, same pattern, what it does, why it matters, and how you prepare it. Beyond the core six, a general exam tray usually holds several smaller instruments, and you should be able to name each one and say what it does. The pen light is a small focused flashlight. Provider shines it to check how the pupils react and to light up the nose and throat. The tuning fork is a metal fork that the provider strikes to make it vibrate, and it's used to test hearing and the sense of vibration during a neurological exam. The tongue depressor, often a disposable wooden blade, simply holds the tongue down so the provider can see the back of the throat. The nasal speculum spreads the nostrils open so the inside of the nose can be inspected. A tape measure is the flexible kind used to measure things like an infant's head circumference, the size of a wound, or a child's growth. And the scale measures weight and often height, which we use to track growth and to calculate medication doses that depend on body weight. None of these are complicated, but a smooth visit depends on them being present and ready. If you know the provider is seeing a child for a well visit, you already have the scale zeroed, the tape measure handy, and a fresh tongue depressor waiting. Supplies are the consumables, the things you use up and have to keep restocking. Gloves are at the top of the list because you wear them for any patient contact as part of standard precautions, and you want several sizes on hand so they actually fit. Gauze and cotton balls are used to apply pressure, clean the skin, and cover a small site after a blood draw or minor procedure. Exam table paper is the roll of paper you pull out fresh for every single patient, which keeps the table sanitary and is one of the first things you change when you turn over a room. Gowns and drapes protect the patient's privacy and let the provider expose only the area being examined. Alcohol pads disinfect the skin before a stick and wipe down the instruments, and lubricant makes certain exams more comfortable. Finally, specimen containers are what you use to collect and, just as importantly, label specimens like urine or swabs before they go to the lab. The theme for supplies is anticipation and stocking. The provider should never reach into an empty box, and a well run room has all of these ready before the patient walks in. When you restock, also watch expiration dates and keep clean and dirty areas separate. This is the heart of the waste section, so let's slow down and take a look at it in detail. Why does it really matter which bin you use? It comes down to three things every time: safety, law, and money. Starting with safety, because it is the most human reason. When waste goes into the wrong place, the person who gets hurt is usually not you. It's the sanitation worker who lifts the bag, the housekeeper who compresses the trash, a coworker, or even a member of the public. A used needle tossed in the regular trash is a needle stick injury waiting to happen, and that injury can transmit hepatitis B, hepatitis C, or HIV. Second, it's the law. OSHA's bloodborne pathogen standard, along with your state's rules, requires that regulated waste and sharps go into labeled, color coded containers. If an inspector finds a sharps container overflowing or a red bag waste in the regular trash, the practice can be cited and fined. Third, and this surprises students, is cost. Biohazard waste disposal is far more expensive than regular trash disposal, sometimes many times more per pound. So, two mistakes cost the office money in opposite directions. If you throw ordinary paper and packaging into red bags, you are paying premium prices to dispose of plain trash. If you throw sharps or biohazard into the regular trash, you risk injuries and fines. And there is an environmental angle too. Regulated waste is treated, usually autoclaved or incinerated, so it is rendered safe rather than dumped. So when you pause for half a second to pick the right container, you are protecting a person, keeping the office legal, and being a good steward of the practice's money. That habit is what separates a careful MA from a careless one. Now let's sort out two of the three streams: regular trash and biohazard waste. This is where students get nervous, but there's a simple test. Regular trash is for everything that is not soaked, dripping, caked, or sharp. That means paper, packaging, wrappers, clean gloves and gowns, used exam table paper, empty containers, and even gauze that has only a small dried spot of blood on it. Most of what comes out of an exam room is actually regular trash. Biohazard waste, which has the formal name of regulated medical waste, goes into the red bag marked with the biohazard symbol. This is for items soaked or dripping with blood or other body fluids, gauze or dressings that are saturated or caked with blood, blood-soaked gloves and PPE, and specimens or other potentially infectious material, which OSHA abbreviates as OPIM. The single most useful test, straight from the OSHA standard, is the squeeze test. If the item would release blood or infectious fluid in a liquid or semi-liquid state if you compressed it, it is regulated waste and goes in the red biohazard bag. If it would not, it's just regular trash. Here's the key nuance students miss. A Band-Aid with a tiny dried spot of blood is just regular trash, but a dressing saturated with blood is biohazard. Do not red bag everything out of fear because that wastes money. And do not underbag truly contaminated items because that endangers people. The squeeze test keeps you honest. The third stream is sharps, and this is the one where a mistake can injure someone in a second, so we give it its own rules. First, what actually is a sharp and what counts as a sharp? Anything that can pierce the skin is a sharp. That includes needles and syringes with the needle attached, lancets, butterflied or winged needles, scalpel blades, suture needles, and broken glass, including glass capillary tubes. Every one of these goes into the sharps container, which is the rigid, puncture-resistant, leak-proof container that is labeled or color-coded, usually red. Now the safe handling rules, because how you handle a sharps matters as much as where it ends up. Drop the sharp into the container immediately after use while it is still in your hand so it never sits on a counter. Never recap a used needle and never bend or break it because that is exactly when most needle sticks happen. Engage the safety device that is built into modern needles. Watch the fill line and swap the container when it reaches about 3/4 of the way full because overfilling means sharps stick out the top and someone could get stuck. Keep the container upright and within arm's reach, never on the floor. And never ever put your hand in a sharps container to push things down or fish something out. If you follow these rules, you protect yourself first and everyone downstream second. Remember the earlier number. Hundreds of thousands of needle stick injuries happen in the U.S. healthcare every year, and almost all of them are preventable with exactly these habits. Let's pull it all together now. There are 5 takeaways. 1. You set the stage. As the MA, you prepare the room, keep supplies stocked, and make sure every instrument is clean, charged, and ready before the patient is roomed so the visit flows smoothly. 2. Know each tool. For every instrument we covered, you should be able to answer 2 questions without hesitation. What does it do, and why is it used? Run the list in your head. Otoscope for the ear, ophthalmoscope for the eye, stethoscope to listen, sphygmomanometer for blood pressure, thermometer for temperature, reflex hammer for reflexes, plus the pen light, tuning fork, tongue depressor, nasal speculum, tape measure, and scale. 3. There are 3 waste streams, not one. Regular trash, biohazard in the red bag, and sharps. 4. Sharps get special respect. Never recap a needle, drop it in immediately, swap the container at 3/4 full, and never reach inside. 5, and the one that I want most to stick. The right bin is a safety, legal, and financial decision. When you are not sure between regular and biohazard, use the squeeze test. If it would release blood when compressed, red bag it. If not, regular trash. Master these and you are ready for the lab where you will actually handle and sort these items. Be sure to complete your guided notes and the self-check and upload them to Brightspace. Here are the sources behind today's lecture, and they are all government or educational sites, so you can trust them and use them yourself. The OSHA Bloodborne Pathogen Standard and its quick reference guide are the legal backbone for regulated waste, sharps, labeling, and color coding. The CDC Sharps disposal page and the FDA Sharps page give the hands-on rules. Do not recap, replace at 3/4 full, use puncture-resistant containers. The CDC Regulated Medical Waste page and the EPA Medical Waste page explain how biohazard waste is defined and treated and remind us that most regulation actually happens at the state level, so always check your own state's rules. The Stat Pearls Otoscope entry from the National Library of Medicine and the Gwinnett College Medical Assisting Guide back up the instrument descriptions. If you want to go deeper on any instrument or any waste rule, start with these references.